Screen share, go. Oh, there we go. Okie dokie. Everyone should see this. So we're going to move on to the next portion, which is having our guest speakers, Dr. Nicole Reynolds and Dr. Jonathan Sham, presenting about key issues affecting healthcare providers in the US. So we're first going to have each of them introduce themselves, and then we will go into discussions. And at the end, there'll be time for questions. So please prepare a question if you have anything on your mind and want to ask near the end when we have time. All right. All right, Dr. Nicole, can you introduce yourself to everyone?
Sure. Hi. Thanks for having me. I'm Nicole Ehrenholtz. I'm happy to join you. I come from University of Washington, where I'm an attending physician and clinical associate professor of medicine. And I have a couple roles to my job. One, of course, is patient care, but my specialty in internal medicine is refugee and international health. So I do primary care for a 100% refugee and immigrant population in Seattle. Excuse me. And then the other important part of my job that I enjoy, probably my favorite part, is working with medical students and residents. And I do teaching and clinical teaching and lectures, and just love getting to work with learners. And then I also work on a separate grant with torture survivors, working with their immigration attorneys on their asylum cases and doing medical evaluations. I'll leave it at that, but yeah, thanks for having me.
Thank you so much. And next, Dr. Jonathan Sham, please introduce yourself as well.
Hi, good morning and good evening, everyone. My name is Jonathan Sham, and I'm a surgeon and researcher at the University of Washington and the Fred Hutchinson Cancer Center. My clinical focus is on diseases of the liver and pancreas and biliary tree. And my research focus is on surgical outcomes and also bioengineering. And this is a lot of words, so please don't read that. But yeah, yeah, I'm sure they'll share it later.
Yes, these will be available on the Google Drive, everyone, for you to review as well. All right, so I'm going to stop sharing the screen and let me see. You know, I think I'm just going to share my screen, if that's okay, Dr. Sham.
Sure, go ahead.
I have it right here. One moment. Okay, there we go. Thanks, Zoom. All right.
Awesome. Well, I'm going to get things started off for us. And again, just have a couple slides here to talk about the health system in the US and give you a little bit of background. Many of you may be familiar with this and maybe not. So it's kind of to bring everyone up to speed. If you go to the next slide, I do just have one disclosure to start off. I'm a surgeon. I'm not a health policy expert by any means. I've just been operating, no pun intended, in this system for the last over a decade or so, and so have had experience with the highs and lows that I'll share with you. So we can go to the next slide. So if you think about models of healthcare, and you may have learned about some of these in your coursework thus far, based on what level of student you are, there are, in general, 4 big models that are seen throughout the world, and we'll just review them briefly here. The first is the Bismarck model, which was founded in Germany in the late 1900s. Essentially, this is financed by employers and employees, but kind of run through the government with tight governmental controls. We see this system in countries like Germany, France, and Japan. and it's quite popular in Latin America as well. In the late 1940s, after World War II, the beverage model came about, and that's so-called socialized medicine. So essentially, everything goes to the government first, and then everything is then paid by the government. That's a single payer system you may have heard of. And then in general, most of the medical care delivery takes place through governmental channels. So, the government actually owns the hospitals and the clinics, and the doctors are employed by the governments with some small exceptions. And you can see this in like Great Britain with the National Health Service, New Zealand, and Scandinavia. Next slide. The national health insurance model is kind of a combination of the two, where essentially you have a single payer system, which is financed through the government, run health insurance. However, doctors and hospitals can be private. They're not necessarily owned by the government itself. And so the money kind of goes through the government into the private sector. And really the regulations come by having very, very clear delineation of what is and is not covered. And everyone knows that up front. We see that in Canada, Taiwan, and as many of you may be familiar, in South Korea as well. And then, of course, the out-of-pocket model, which I'll say, unfortunately, is one of the most common models in the world. And that's essentially you pay for services if you have money, and if you don't have money, you don't get services. And unfortunately, this is predominantly a system in a lot of the developing world, because the systems are not organized to deliver care, particularly to the poor. And it may or may not be surprising, but is also a system seen here in the United States, and was a predominant system up until 2018 here. So the next slide, please. So in the US, there really is a mishmash, a combination of all four of these models based on various populations. We call it the Veterans Affairs Service. So people who used to be in the military, the US military, have this beverage model. The Medicare and Medicaid system is more of a NHIS model, and that's about half the population. A lot of those persons who work and have jobs and employer-related health insurance have this Bismarck model. And then again, unfortunately, a lot of folks who don't have job-related insurance, either who are unemployed or just their employers don't offer insurance, are stuck with this out-of-pocket model. Fortunately, this number is a little bit lower. This slide is a little old because of the Affordable Care Act. So this number is down to about 9% from 15%, but still a very large population. Next slide. So again, just a picture looking at how utterly confusing the US healthcare finance system is. You have multiple government entities funding private and public sector healthcare delivery systems, and then essentially managed care organizations and insurance companies helping to pay for that, and in some instances determine what care can and cannot be delivered. Next slide. This is a rather just very, I'll say, famous slide that you see in a lot of these presentations that just shows the United States spends a lot on healthcare. Healthcare spending as a percentage of GDP, we spend more on healthcare than any other country in the world. And that is both as a percentage of GDP and just the total dollars per capita. You can see that we're astonishingly high. Next slide. And unfortunately, despite spending all this money, our outcomes are not the best in the world. South Korea, Japan, far better outcomes than the United States, which you can see on the right side in red, were quite bad when it comes to access, quality, efficiency, and then of course, health expenditures. You can see in 2007, we were about $7,000. And then next slide, we're up to $8,000 just 4 years later. And again, similarly, this data is out of Johns Hopkins, access, quality, life expectancy, really near the bottom. So the point being, we spend a lot of money and we're not really getting the outcomes that we're hoping to get. And so there's a mismatch there that we'll talk about a bit, I'm sure, in our roundtable. I think that's the last slide, if my memory serves me. Yes. So I'll kind of leave it at that, and happy to chat more, but I think Dr. Ehrenholz is going to chat a bit now too.
And get to the next one. Okay. All right.
All right. Well, thanks, Dr. Sham, for that background information. I think that's going to be really helpful as we continue the next part of the talk. And I wanted to take it down to a patient level. Since I'm not in health policy, I don't work at the government level. I work on a very individual one-on-one level doing patient care. And so this is the level that I interface with the healthcare system. And so I wanted to bring a few cases of example patients, not real patients, but patients who are similar to my patients. So we can talk about some of the issues in healthcare from that level. So one of the questions that was presented, or that Jason asked, was what are some of the hurdles in treatment of patients in the US healthcare system? So I wanted to bring up a case of a young man, so say Mr. MG, and he's 35 and was just hospitalized with diabetic ketoacidosis, a new diagnosis of diabetes. And so he's being discharged from the hospital. And let's go to the next slide to see what will happen next. So insurance is, to be honest, a nightmare in America. And depending on your insurance depends on what happens at this point. So in scenario number one, which is a lot of my patients, if you have no insurance, if you're in that unlucky group who doesn't have employer have covered healthcare, government funded like Medicaid or Medicare, you end up paying a lot out of pocket. And what happens if you can't pay? So as I mentioned, my career, since I finished medical school 16 years ago, my career really has been to this population of people who don't have resources. So what would happen if Mr. G gets discharged from the hospital? Well, the problem is in the hospital in America, emergency care is covered. So if you show up at the ER and you're sick, you will be taken care of, no questions asked. However, once you get out of the hospital, how do you get a doctor to see you in clinic, and how do you get medications and supplies? And this is where it's very piecemeal. So some people, if you're fortunate to live in a place, in Seattle, we have Harborview, which is the hospital I work at, where we have a robust charity care financial assistance program. You can apply, and some people, a lot of people are granted charity, so that you can find a doctor, you can get your medications paid for, and you can, continue to get your care in a non-emergency setting. If you're unlucky, if you don't live somewhere close by, if you're in a rural area or somewhere, a different state that doesn't have those services, then a lot of times you're out of luck. Your disease gets worse and worse until you end up in a hospital again, and then you get your emergency care, and then you get discharged and have nowhere to go. So that's scenario one. Scenario two is you have private insurance. So if you're employed and you're lucky enough to have a job that has coverage, then you will oftentimes be able to get your medications and be able to see a doctor. However, then you're subject to sometimes even private insurances have really expensive, unaffordable copays and costs for medication. So that can be difficult also. Scenario three, if you're on Medicaid, which is the government assistance for low-income people, then sometimes it's a struggle to find hospitals or doctors that accept Medicaid. At Harborview, we do, of course, But then you're also subject to formularies and restrictions. It can be difficult sometimes to get the services you need or get the medications that you need. Next slide. The other thing I wanted to bring up as an issue of how it's difficult, or what issues that patients face and what healthcare providers face in the US is that there's so much of health that's related to not just the hospital and the pills and the medications that you take, but everything else in your life. So say Mr. MG, it lives in an inner city that's maybe crowded and polluted and doesn't have access to healthy food because healthy food is expensive and junk food is cheap in America. If he doesn't have transportation, if he's reliant on trying to find buses to get to the hospital, if he maybe, in the case of a lot of my patients, if he can't read or write in English, or some patients can't read or write in their own native language, if they don't have money to pay for copays or even to pay for the bus to get to the hospital, all of these things will impact your care and your ability to take care of patients and your ability for them to get the health care that they need. So it's complex, as doctors, we know our patients are, they live 99.9% of their lives out of the hospital. We only see them for a very small part of their lives and are trying to make an impact in their health, but we know we're up against many other factors. Next slide. The next question that Jason asked was, what are some of the processes and challenges of processing insurance claims for services a physician deems necessary and insurance might contest? So I brought another case. This is an actual patient of mine that I saw. Another patient, a 72-year-old woman who slipped and fell in her bathtub, hitting her head. She comes to you in clinic and she has a headache, but otherwise her exam is normal. But she's on blood thinners. And so you're worried about bleeding in the brain and you want to get a head CT. But her insurance, like many insurances, Medicaid, will take weeks to process a CT and you can't wait for weeks. So what do you do? So this is unfortunately a real life scenario that happens all the time. What happens for CTs if you order them on a lot of people's insurances is insurance will initially deny it and they will send you forms and then you fill out the forms and fax them back. And then after some days, they might deny that again. And then they might say, no, we need to do what's called a peer-to-peer discussion where they make a physician set aside time to spend on hold, calling, fighting with the insurance company and making a case for why this patient needs a CT scan. And then finally, maybe it will get approved. But in a lot of cases, we don't have time to wait. We don't have weeks to wait for these things. And so unfortunately, these patients often have to go to the emergency room to get the care that they need because our hands are tied in clinic with insurance. Next slide. Sorry, we're kind of flying through these a little bit, but we'll stop for questions at the end. I'm sure each of these topics could be a whole discussion in themselves. But the next question was, how do you feel time constraints factor in possible medical errors? And do you believe there's a correlation? This was a tricky one. I couldn't find specific studies about this, but I can say from experience and in training, when you are overloaded with patients and there's not enough time and there's not enough people and not enough help, I think it is very easy to make mistakes. And I hope that there's enough, I think there's many safeguards in medicine. We're not a solo act. We work as part of a team. And so there should be layers of backup to help reduce errors. But I do think this is a significant problem, especially as there's shortages of doctors in the United States and people are being asked to do more and more. So I believe there is. Next slide.
Can I ask a follow-up question?
Yes.
Do you think like having more medical staff to be able to like take some of the work away from doctors would help more alleviate some time restraints or errors or anything? Is there like possibility for that in like budgets, or is it kind of difficult? I think it leads into your next slide. But
Yeah, I think that's a great question. So I think it really depends because sometimes, they've tried different things to reduce physician workload and burden. such as having scribes do some of the clerical work that we get, we're asked to do a lot of charting, a lot of recording things on the computer rather than spending time face-to-face with patients. So they've tried hiring kind of clerical staff. And I don't know how much that helps, honestly. I think it's often a problem of not enough actual physicians for the number of patients that there are. But I don't know, Dr. Shamdi, if you have other feelings on this from the surgical perspective.
Yeah, it's a great question. We use a lot of advanced practice providers, so nurse practitioners or physician's assistants. They're really critical in our service model because there may be 2 or 3 days in a week where I'm literally unreachable for 10 to 12 hours at a time when I'm operating. And so given kind of those time constraints, kind of just doing other types of medical care delivery, they really do play a vital role in our care model.
All right, thank you so much. Shall we move to the next one?
Please. All right, the next question was about the nursing and physician shortage over the years. How has that affected the medical system in Seattle? And has the COVID pandemic affected this shortage? And what are the solutions and perspectives healthcare providers are taking to solve this issue? Yeah, this I think we touched on a little bit, but there is and there will be a huge shortage of physicians in America. And the AMA, I think the reference probably got cut off on the bottom of the slide, but in one study projected a physician shortage by 2034 in primary care. You can see the numbers there, up to 48,000 physicians, and in non-primary care specialties as high as 77,100 physicians by 2034. As far as a response, so in 2020, Congress added 1,000 new Medicare supported GME positions, so residency positions over the course of 5 years. So you can tell it's just a tiny amount of the shortfall of the shortage of physicians there will be. So, and that will take 5 years even. So some of the things that people have tried to solve, I think, as Dr. Shah mentioned, training physicians assistants and nurse practitioners. And I think that will help in certain arenas more than others, but the training is very different than training medical doctors, training physicians, MDs and DOs. And so I think it will help in some ways and not help in other ways. I think the shortage in Seattle, we've definitely felt it, especially in nursing shortages during the pandemic. And lots of nurses have left and either stopped nursing or traveled to other places because they get paid more to travel around than to stay in one hospital. Can you go to the next slide? I think I'm talking. Yeah, and so I wanted to just highlight, it's not just staffing shortages in the hospital that were a problem, but it's staffing shortages across the board, because in this flow chart, you can kind of see how patients move through the system. They might go to a community clinic or one of our clinics. If they're sick, we send them to emergency room. The emergency room then can admit them to the hospital. And then once they're well enough to leave the hospital, they can move on to a skilled nursing facility or a rehabilitation center for care. But all of these domains, every single one was hit really hard during the COVID pandemic. And particularly in the nursing homes, there became no way to discharge patients from the hospital because there were no nursing home beds available. And so the hospitals became very full, not just with acutely ill patients, but people who had no place to go, no place to leave the hospital. And thus the emergency room got backed up and were boarding hospital patients. And then patients who were very sick waited in the ER for hours and hours and hours because the ERs were already overrun with people boarding there or hospital patients staying there. Meanwhile, we're trying to stay afloat in clinic and keep people out of the hospitals as best we can, but everywhere was hit really hard by the pandemic. I think that's all I had to say on that part. The last question I think was open-ended on the next slide about other issues. Oh, I wanted to bring out, and I think this ties in with the pandemic as well. Other issues that we haven't discussed being burnout. Burnout is a huge problem in medicine. Burnout is defined as work-related stress, a stress syndrome that results from chronic exposure to job stress. So when people are just overwhelmed at work and just bombarded constantly with more and more than they can handle, it can result in just being emotionally exhausted, and people can become cynical and depersonalized. So it's hard to think of a patient as a human being with a family and a life, but they're just another person who's needing your care, and another person and another person. And then a lack of sense of personal accomplishment. We can wonder, what are we doing here? Are we making a difference at all? There's just so much more need than there is our ability to handle that need. So I think this is a huge issue, especially during the pandemic, as we've all been asked to do more and more in helping cover hospitalized patients. Yeah, and that's all I had for prepared comments, but I would love to hear questions and other people's experiences, yeah, from their perspective.
I'm going to stop sharing my screen. So this is the open section. If you have a question or want to follow up with something that was just discussed, I will grab the questions really quick and put them in the chat we just talked about.
I have a question for Dr. Sham, if that's okay. You were mentioning how in your medical field you assist refugees coming into Seattle, and correct?
I think that was maybe Dr. Aaron Holtz.
Okay, sorry, my bad. It was a lot of information to take in. Sorry. So I know that a lot of refugees, when they come into the country, they don't have the proper financial resources to afford the medical care here, even with Medicaid and Medicare and all that. How do you deal with funding to help the refugees who are coming in?
Yeah, thanks for that question. It's very important. So actually, in terms of insurance, refugees are one of our best, one of the best ways to come into America, because you will automatically qualify for Medicaid. It's a lot harder for our patients who are undocumented, so coming before they have papers, or for the asylum seekers that we see are often in a much harder place, even though they come same as refugees in the sense that they're fleeing persecution. They come before they have their status. And so they come here with nothing. And those are the most, I think, vulnerable, undocumented and, asylum seekers. There are certain programs. So that's one of the programs I work with, one of the grants, trying to work with asylum seekers because they're so vulnerable and they don't qualify for Medicaid right away. If they live in King County around the University of Washington, we have a nurse and social worker who can get them connected with the financial department at Harborview to try to get them charity care so that we can assist them and take care of their medical needs while their asylum case is in process. And it's a three-way partnership. So there's us, we do the medical part of things, and then we work with immigration attorneys, a nonprofit group who's doing their immigration case, and we can provide evaluations to help them with that. And then we work with mental health providers, counselors, to help with all the trauma that they've suffered that led them to flee their country.
Thank you. Thank you for that. I was curious to know. Thank you.
Thank you.
And just
Hi.
oh, go ahead, please.
Okay. Hi, I have a question. I would like to know from your presentation, you mentioned that when people come in through the emergency, then they have like coverage. So I'm so new to this and I don't really understand the whole thing, but do you have cases where people intentionally cause like emergency because they want to treat old cases? And in that case, do you treat the old cases, or are you just going to treat the emergency cases that they came with?
Yes, I'm sorry, I should clarify. When people come to the emergency room, they will get care no matter what. They don't ask right up front for money, but
Okay.
they will later receive a giant astronomical bill. And so that can be devastating financially. There's things people can do to try to reduce it, but I should have said they don't have coverage, but they will get care. They won't let them die just because of a lack of ability to pay, but those bills will hurt later on.
Okay.
Yeah, sorry about
Thank
that.
you.
I should also
Thank you.
clarify, the emergency room, their job really is just to stabilize the patient and get them where they need to go. So if a patient, like so one of my patients comes and they have chronic back pain, the emergency room will determine, okay, this isn't life-threatening. We're done here. You can follow up with a regular doctor, and they won't necessarily go into the long-term workup, refer to physical therapy, plan, whether they need what type of services or not. It's mostly because they're trying to save lives and deal with acute problems. They will triage to either admit people to the hospital if they're sick enough, or send them out to, hopefully they'll have a primary care doctor, but not everyone does.
Wow. Thank you.
And as a follow-up to that, part of the frustration with the US healthcare system, and this does apply to other countries as well, is that there's really no transparency about pricing. It's not like there's no menu. The price for an X-ray or a CT or a medication is not on the wall when you walk in. And actually how much you're charged is oftentimes different based on if you have insurance or not, because the insurance companies will have negotiated pricing with the hospital or healthcare system. And so in a weird kind of backwards way, sometimes those who have no insurance actually get charged the most. It seems backwards, but that's the way it is with this system. There's a big movement against so-called surprise billing, because oftentimes when people will go into the emergency department, or maybe get taken by an ambulance somewhere, they don't really have a choice of where they go necessarily based on the type of injury they have. And then all of this stuff is done to them, either usually for better, sometimes for better, for worse. And then they get a bill, as Dr. Ehrenholz said, 3 months later, that is equal to their entire yearly paycheck, let's say, or their salary. And so there's a big movement to try and prevent this, because it doesn't make any rational sense, right? I mean, this shouldn't be happening, particularly in a developed country and developed health system. But because of, as I showed, we're this hobbled together system of all of these different types of healthcare delivery models, there's really no unified way to do this, but we're slowly inching there, little by little.
I can provide an example of a personal experience with that. When my husband and I first reached the States, we were still getting accustomed to here and still setting up our insurance. And he had an accident on one of those electrical scooters and broke his nose. And so we went to the emergency room, Ubered to the emergency room because the ambulance is expensive. And we hadn't had our insurance fully set up yet. So we went to the emergency room. We stayed there for like 4 or 5 hours. They were doing a bunch of tests. And then the next day he went to a specialist so that he can do a surgery right away and fix the bone before it started healing. And a month later, we get a bill of about $15,000 to pay off. And we were getting into setting up our insurance. So luckily the insurance covered like 90% of that, which was great. But yeah, we didn't know that it was going to be that much. We weren't used to that kind of system. And like they show you in the bill, like there's the CT scan, there's this blood work, there's this and this and that. So when you get the bill, it's very surprising. But fortunately, if you have the right kind of insurance, you're mostly covered off of that.
Wow. Mm.
Yeah, I know it's a lot to take in. Yeah.
I'm just thinking, what happens if somebody can't foot that bill? What
If some-
happens is if somebody, like, after all the process and somebody just can't take care of that bill, like because of normal things that we do, all the paycheck goes to somewhere else, then what happens? Is it like going to be inherited to your great grandchildren or something like that? Or does it cancel out after a while?
Well, it depends is the answer. Some
Mm.
hospitals will actually go after you and will actually
Mm.
send to collections. They'll actually use a company to try and get the money back. The statistic may be a little bit better now, but at least in 2018, there was something like 5 or 6% of people had to enter bankruptcy who went to the hospital because they couldn't pay their medical bill. So it's a big problem. It's a big problem that shouldn't be happening.
Yeah. Thank you. I'm so interested in this because I worked in Ghana as an emergency nurse as well. And I knew we had problems then, but then this is just opening my eyes to a whole different type of problem in the system. So thank you for the clarification.
I am really glad I'm in Japan after hearing this. Ambulance service is free. Yeah, so sometimes they have to tell people don't use the ambulance as a taxi. But anyway, yeah, and a lot of other things are much, much cheaper and a lot easier here in Japan, I think. I'm interested in hearing from Korea. What is the situation? Is it more similar to the States or more similar to Japan? I know, Dr. Sham, you explained a little bit, but I don't remember that all of it.
And as a Korean, in Korea, we are like almost same as Japan. We have free ambulance, and the government government have the national insurance of healthcare. So every clinic, every hospital should take the government insurance. So it's way cheaper than US.
Yeah. Can you choose the hospital or the doctor that you want?
Yes.
Okay, yeah, same here. Same in Japan. Yeah.
You don't need a referral or anything. When I lived in Korea, I just went straight to any doctor. Like even when I went to Yonsei University Hospital, they just said, okay, sure, come in, and directly the big university hospital. And I didn't have insurance in Korea at the time because I was just a student studying, and it was like only $100 to see a doctor and get all the medication, do all the things. So it was really, really affordable.
In Korea, we have referral system. So when you go to the secondary or tertiary hospital, you need some referring letter from the primary clinician. But when you go to that kind of hospital without the referring letter, you need to just pay twice or 3 times more, and everything is okay.
I see. Interesting.
I also have a question about outreach. Are medical services from the hospital or maybe from a public health perspective? I know, for example, in Japan, after a woman has a baby, they send a nurse to her home to like a month after, and then follow up for maybe about a year. If you don't need the service, you can refuse, but to help teach, especially now, they don't live in a extended family, so there's no one to teach the new mother about how to care for her child. So they come to monitor the health of the baby and also to help with any questions the new mother has. Are there any services like that in the US? This is outside your field, I know, but in case you might have some information.
I'll say in general, no. Outreach is probably much more in Dr. Ehrenhold's wheelhouse than mine, but a lot of it is patient driven, and a lot of it, unfortunately, is about who you know and who you're familiar with. And in a similar system, as Youngha just said, you need a referral to go to a specialist in general for many insurances. But again, the home-based approach, for example, my wife, when she delivered our child, was having difficulty breastfeeding. And in order to even and this is someone who has resources, who has a physician, who has insurance, who is going to the hospital where her husband works, right? And despite all of those advantages, was having difficulty getting a hold of like the breastfeeding nurse and team. So it's a bit on the other side of the spectrum from what you were describing.
Yeah, I would like to add, we have on a national level, nothing that robust or wonderful. At Harborview, so at the clinic or the hospital and programs that I work with, we actually do have a program called House Calls program, and it's also community and cultural mediators. So for our particularly high needing refugee and immigrant population, we have interpreters who don't just work interpreting words back and forth just in the encounters, but they're also cultural mediators who help bridge the gap. Like in the previous presentation, actually, I enjoyed listening in a little bit on the cultural divide. And so these interpreters, these cultural mediators help bridge that between the not just the American system, but American medical system, which is its own confusing entity, and then where the patient is coming from. And so we sometimes do house call, go to the patient's houses with the community house calls, the cultural mediator, so we can understand what's the problem, who's living in the home, what is the living situation like, do you have access to food, water, place to walk, things like that. But this is, again, one small program within one hospital within the city and within the country. So not on a large scale level, but it is one of the reasons that we're able to do the work we do in our clinic.
Is there something like that assistance in Japan or Korea with patients? Like cultural trying to understanding? How common is that these days? Does anyone know?
I know that Ruth Sensei is working with some volunteers, so I know there are some volunteers that help, but I don't think there is any like concrete system and most of the volunteers do kind of like interpretation. I don't think maybe they are trained, but yeah, recently they are getting some good training on like cultural sensitivity and how things are different from different aspects, but that's just in Matiyama. I don't know about the other places.
I'll just add, kind of talking a bit back about how care delivery is regulated, kind of on the different systems, to give you a sense of how it's done in the US. In like nationalized systems, true socialized systems, that go kind of top down from the government. Really, the government is deciding what care is warranted, we'll say, or what is indicated in any given situation. And that scares a lot of Americans for some reason. They think that freedom is somehow being impinged upon at times. However, even in the US, there are still limitations. It's just instead of at the beginning, it's on the other side, it's at the end. So I, as a surgeon, I can do whatever surgery I want to do on any patient. It seems crazy, but I can do that. But insurance will not pay for it on the back end. So my point is the regulation, the pinch, that what's preventing me from doing, not indicated surgery from a financial standpoint, not an ethical standpoint, from a financial standpoint, is the fact that I'll know that at the end of the day, my hospital or I won't get compensated if I do a so-called unindicated or inappropriate surgery. So again, it's just a matter of whether it's coming from the top or the bottom, where that pinch is from. Unfortunately, when it's coming from the bottom, it leads to a lot more care delivered than probably should be, and that's why how much money we spend per capita and as a percentage of our GDP is so much higher than all the other countries in the world. Just to give you some perspective on that. And I guess just also to remark on something Dr. Ehrenholz pointed out, she described this system of pre-authorization. So that's where let's say I want to do a surgery. Let's say I want to do I want to take out someone's gallbladder because they have gallbladder cancer, we'll say. Sometimes I will have to get on the phone, with someone to explain to them why I want to take out this patient's gallbladder. The problem is when you have very highly specialized fields like let's say mine, where I'm very focused, I'm very narrow on cancer surgery of the liver and biliary tree. Oftentimes, the person I'm speaking to at the insurance company is, no offense, Dr. Arnold, a general internist or an emergency room physician or a neurologist or someone who has no idea, what I do or kind of anything about this field. They're just reading this paper that, they were given from the insurance company. That can cause a lot of problems because certainly if you don't have that perspective and expertise in a very narrow field, it can lead to delays in care. And I've had patients who've had to essentially agree to say, hey, yeah, I'll pay for my own surgery because my insurance won't cover it for one reason or another. And then we do a lot of fighting on the back end to try and get it covered. So it's certainly a lot of stress on the patient, both emotionally and financially, but it's also a lot of stress on the physician and the healthcare system. And that's time that I could be spending caring for other patients, but I'm on the phone with the insurance company instead. So it goes both ways.
Wow.
I have another question. I think it somewhat relates to what was just discussed. So I'm currently studying bioengineering at the UW, and I was very curious about how these new bioengineered technologies and devices influence healthcare access, especially in regards to what you talked about costs. Like, I feel like there's already a lot of complicated parts with just implementing new technology and the fact that new technology is expensive, but we need more money to make it cheaper. I guess I was curious, Dr. Sham, your perspective on the impact of bioengineered technologies on healthcare access.
It's a great question and very complicated, but I'll try to sum it up briefly. In short, a company can charge whatever they want for a new technology. And we typically see this in drug pricing, where you have some ridiculous cost of a drug that in some cases is warranted, quite frankly, because as you know, a lot of time and effort go into developing new technologies. Now, I'm on the HTCC, which is a committee in the state of Washington that actually determines what the state will cover, which technologies they'll cover and why. And essentially, it's this long process where we get all the data, experts come in and talk about, let's say, spinal, I can't talk about any kind of specific thing, but we'll say this drug A, and does it work for this condition? We'll say diabetes. So does drug A work for diabetes? And we go through all of the information. interestingly, we're not allowed to take cost into consideration on whether or not the state will cover it. So that's kind of the crux of your question, is all we can do by law is look at whether or not it's effective and whether the data support its use in a purely medical context. Whether it costs $1 or $1 million, it doesn't matter at all. And we're instructed not to even pay attention to that. So it's part of the reason why healthcare costs are so high here, but not the sole reason. I say probably not even the majority, not the major reason. I'd say excess care delivery on perhaps unindicated procedures or medications is a large component. But new technologies, while expensive, I think are something that we're all willing to pay for and develop, given that's really what's moving the field forward.
That makes sense. Thank you.
So I have a question. Are the drugs affordable in drugstore? Because like people don't want to go to the hospital because it's expensive. So I think like they want to get better by just taking medicine.
I'll take a stab at that one, Nicole. It depends, I guess, is the answer. Because of how US patent law is written, drugs are protected for a certain amount of time, at least 7 years or so, and that allows a company to be the sole producer or seller of that drug. And then once it goes off patent, other companies can create that drug. Generally speaking, the generic drugs are much cheaper, maybe even pennies, compared to hundreds of dollars. And so older drugs, more common drugs, tend to be very affordable. Newer drugs, more select drugs that are still on patent, tend to be more expensive. That being said, drug pricing is very similar to what Dr. Arnold was speaking about like hospital charges. You don't pay necessarily what the drug costs. The insurance pays for it, and you pay the insurance. And so it's the same thing where the drug company can have a negotiated lower cost for a particular drug, but you're just paying your insurance, and so you don't see that increased costs. So it's the exact same game is played at the pharmacy that is played at the hospital.
I see. Thank you.
Yeah, I would just also add that a lot of drugs that are over the counter in other countries are by prescription only in the United States. And so in order to get those medications, you would need to see a doctor to get a prescription so that you can get them at the pharmacy. One example is antibiotics. I know are widely available in a lot of other countries, but not in the United States. So for infections, you would need to see a doctor, get your prescription, and then go to the pharmacy to get your antibiotic.
All right. Thank you so much, everyone, for discussing. We're coming to the end of our time. I just wanted to say thank you so much to Nicole Ehrenholz and Jonathan Sham. Thank you both for coming here. If everyone can round of applause, give me some hands clapping, some emojis, Thank you so much for coming here. Really appreciate it. And I want to turn it over back to Ellen for this last bit.
Great. Hi, everybody.